I'll show you why you need to be physicians and why you need to be specifically stroke physicians. So I'll put my case down as this. If you're a surgeon, you would know that. So you don't need to listen to me. You can just turn off, because if you're a surgeon, you would have known by now. But if you're not sure what kind of a physician to be, this is what you need to be listening to. Okay. Right. So I'm gonna start with 3 cases. Okay, and that will make my case of you to become specifically a stroke physician, why you need to be a stroke physician. So this is an 84-year-old gentleman, came with a severe stroke, and that affected the left side of his body. He wasn't able to lift his arm, leg at all, facial droop. His gaze was very fixated into one direction. He wouldn't be able to live his life as he was before this. So now, I don't know if the pointer work on this one or not, but I'll try. Yeah. So it will work on the wall, but not this. So you can see here the clot that we could see in the right MCA. Okay. So this is the right main artery of the brain. Must have traveled from somewhere. So if you do the scan again the next day, that whole hemisphere would have gone, okay? And he probably was gonna die, all right? He was given thrombolysis treatment, so he was given clot busting treatment, the same the cardiologist used to use for heart attacks. And the next day, you cannot see the MCA because you're not meant to see the MCA. That means the clot has disappeared. He completely is recovered. He had a carotid Doppler which showed very severe stenosis, and he went to have carotid endarterectomy, and the surgeons were successful in the operation. A couple of days later, he went home, fully functioning, no deficit whatsoever. His life is back on track. Now, 10-15 years ago, that wouldn't be a possibility. He would have to live with this, and not for very long, and then he would die. This is the most likely outcome. This is another case. However, it's a female patient, the same age, known to have aortic stenosis. She had a CT scan, and she had a CT angiogram after that. The CT scan showed the MCA is again blocked, and she was thrombolized, so she was given the clot busting treatment. Unfortunately, there was no benefit of thrombolysis because there is so much that the medication can get through. So we contacted the Queen Elizabeth Hospital to try and fish it out. And this is exactly what they did. So she went to Queen Elizabeth. You could see, so this is the carotid artery that is going to the brain, and this is the MCA should be there, but you cannot see it clearly because it's blocked. And this black bit is the dye that they give to see which artery is blocked. And you can see there's nothing going there. If I tell you this is from the heart, just from there, you would probably believe it because it's the same thing they use in cardiology. So there is a blockage there. They fished it out and they gave the same dye again, and there you go. This has all happened within 6 hours. So from patient not able to walk, not able to talk, would have died most likely within 3 months, to the arteries working again. And a few days later, she contracted a chest infection and recovered from it. And this is the only deficit. Mild arm weakness that has recovered within a week. And when I rang her a week later, she was living again back, with her husband, full life, full function, no deficit, no care, nothing. Her life is back on track. Now, this is the reason why you need to consider this, this specialty. 71 years old man with Crohn's disease. He presented with right-sided weakness, so not far from the others. We did a CT scan, which you could see the artery is blocked. It's pretty easy. So we know what the problem is. We gave clot busting treatment. It did not work. Okay? So we did an angiogram to see the blockage, and we could see there's a clot. We could see it. And the only thing we could have done then to save his life is to fish it out. We couldn't do that because there aren't many stroke physicians and there aren't many interventional neuroradiologists that can do that. We contacted the local hospital. They couldn't do it, and simply because it's out of hours, it's 5 o'clock. This is the only reason why this patient the next day ended up with this and died the day after. Simply because there aren't enough people to do this procedure. There aren't enough of you that are interested in this, in saving these. How easy is that? We're not talking about improving quality of life. We're not talking about being able to do sport. We're talking about saving lives. Do you know how many lives, how many procedures do you need to do to save one life? 3. So you do 3, one of them will be back to normal function or function independently. Number needed to treat 3. How many PCI you need to do to save one life? 32. Yet, if I tell you a patient had a heart attack, went to the hospital, they couldn't have the PCI, which is a very kind of similar to this procedure, but it's very common, because it was 5 o'clock, it would make the news. The patient would still live with a heart attack. Okay, many patients live with a heart attack. This is the reason it's 32 to save one life. Yet this, you probably haven't heard of that, have you? So this is reality. You went to medical school to save lives. This is why I do what I do. And you look at what's the most common killer in medicine, in the world, and you try and target that to save lives. It's the second common cause of death. Yet, not even a quarter of the money spent on stroke compared to the money spent on cancer. Twice as much women die of a stroke than breast cancer, and more than prostate and testicular cancer combined. The lovely team, multidisciplinary team, there will be your family if you become stroke physicians, and simply by being there in that friendly team, you will actually save lives, just simply by putting them into a stroke unit, not even giving them thrombolysis, not doing thrombectomy. You give them thrombolysis within 1.5 hours, you save, out of 5, you save 1. Number needed to treat 5. You do the thrombolysis if you walk slowly, and you end up being there after 1.5 hours, the number goes to 9. So the pace that you walk can literally save life. It does not get any more exciting than this. I did orthopedics when I was an FY2, and it was the most amazing. Patient came with a fractured neck of femur, wasn't not able to walk, of course, and the next day the patient was walking. And I thought, this is just amazing. This is what I want to do, because it's just so fast. The results are so fast. But when I know about this, I think this is just unacceptable, absolutely. 21 years old could end up in a vegetative state and die, while with a procedure like this or a treatment like this, they could be saved. So I'm not sure I need to work harder to make my case here. If you're not convinced by this to become physicians, not any physicians, stroke physicians, I'm wasting my breath. I do not need to do any more. So my case is done. This is the team that you will be working with. That will be your family. You do not get this with many other teams, in a hospital environment, to have a family like this. We are like a family. We see them every day. We joke. It's fun. I go to work because I like it. I really, really like it. I wake up in the morning and say, you know what? I'm just going to have fun. It's the most fun that you could have legally in a hospital environment. What do I do in a typical week? Well, I could do whatever I wish, I suppose, once you are in that position. But you could do whatever. If you like clinics, there are so many clinics. You could do a clinic every day. You could see so many conditions that present like stroke or a TIA. So many of them. You need to know a lot about them. And that is the reason why you need to be a physician. If you want to walk fast and run, you be on call. And we do a week on call at the time when we run to the A&E and save lives. We do rehab when we are tired. So the next week, the week after that, we're pretty exhausted. We say, you know what, we want a relaxing week. We look after rehabilitation patients where we do twice weekly ward round and just the rest of the time do nothing. It's absolutely. Why wouldn't you want to do that? Once in a while, if you're interested in medicine, if you're interested in acute medicine, we do acute medicine shifts. If you want to work with old people, then you can do geriatrics. If you want to do, if you want to be a detective, and I'm sure Holger will tell you all about it, then you can be a neurologist. So you can be a neurologist and be a stroke physician. Acute, you can do acute medicine and still do a stroke medicine. You can do geriatrics and still be a stroke physician. So there are so many ways you can be a stroke physician. You only need to do 1 year extra on your training to become a stroke physician. So I do not care what you become, a neurologist, acute physician, or geriatrician, as long as you have to be a stroke physician, because this is when you will save lives. And then you can do it half your time, quarter of your time, a third of your time. You can literally choose. This is how desperate hospitals are in getting stroke physicians, because it's just rare, yet it's the most exciting. You can become a neuroradiologist and do it, but in the future, I tell you that, in the future, it's not the cardiologist that will do this procedure. A neuroradiologist will be busy pleasing the neurosurgeons. So it will be you. It will be you that will do this, and you could choose that. But there aren't enough of you even to consider a training program in order to train to do this. So if you want to have if you like your DIY, then you could be the one doing this. If you want to be in clinic, there's a clinic environment in this. Wards, there you go. So it's very variable. You never get bored of it. It's my life. I love it, so that's what I do in my whole week. I just do stroke because I just like it so much. So why to become a stroke physician? Because it's pretty easy. There isn't much to it really. You look at the patient will tell you what they have. You look after scans. It wasn't very difficult for you to see where the problem is. You do not need a radiologist to tell you what the problem is. You will become expert at interpreting scans. It will be you, because it's pretty easy. There is not much into it. Yet, it's the fastest way to save lives. Win-win situation, in my view. It has great potential if you want to do any of these things. It does save lives, and it is adaptable. I don't think I'll be running when I'm 60. I'll be doing more rehabilitation and Botox clinics and spasticity, and to try and improve the quality of life after stroke, which cost billions and billions, and more than that, cost patients their quality of life. And so wherever you are in your career, you will be doing things to help patients, either to help their lives, to save their lives, or to help their quality of life. So I'm hoping that I don't need to say anything more, really. So what can you do to become a stroke physician? Simply come and see us. Come to our wards and see how we work. Okay? See what we do. Request a placement in stroke department. So when you graduate, this is where you want to spend 4 months of your career, in the stroke department. You need to ask for it. We have so many audits, so many research projects. We are already involved in 4, now 5 research studies. So if you're interested in the academia, absolutely it's the easiest way. So many studies. We cherry pick, actually, our studies. You could attend stroke conferences. There are so many of them. The European one is in Milan, so you could use it as an excuse if you want to go there. There are trainee weekends, the BASP trainee weekends, which run, I think, once or twice a year. And you need to be interested in medicine, because if you need to be interested in surgery, you might want to wake up in 40 minutes. Thank you very much.